Okay, good evening, everyone. Come on. Good evening, everyone. Evening. All right. I'd like to welcome everyone once again to our ERAD CBD event. To those that are our regular customers now, thus far, this is our third one for the year, and we are happy that we are growing to bigger and better things, if I can say so. Tonight, oh yes, let me introduce myself. I am Aleta Land. I am the Chief Radiographer at ERAD Radiology. And tonight's topic will be presented by Dr. Andrew Lawson, our visiting diagnostic and interventional radiologist. The topic is on endovascular therapies for benign prostatic hypertrophy and osteoarthritic joints, basically keeping it in between the hips and the knees, as Dr. Lawson has quoted it. I do hope that everyone will enjoy the topic. I'm sure for some of us, it will be the first time hearing about this type of therapies, and I do hope that it's a learning experience for everyone. Introduction on Dr. Lawson to those that don't know him. Dr. Lawson is a diagnostic and interventional radiologist based in Pretoria, South Africa. He qualified as a doctor at the University of the Witwatersrand and trained in radiology at Prostate Hospital in Cape Town. He received extra training in endovascular therapies for benign disease while at the Royal Surrey Hospital and Southampton Hospitals in England, and spent a further year in Australia gaining experience in diagnostic magnetic resonance imaging, MRI. He was the lead author and the research director of the UAE, the Uterine Artery Embolization Services offered at Grooteskier and Tygerberg Hospitals in Cape Town. And he is the coordinator of the Fibroid Care Initiative and has brought the UAE services to Namibia, Botswana, Tanzania, and Kenya, to name just a few. He also runs the Prostate Care Initiative, with his center currently in the top 10 institutes in the world, having exceeded over 200 prostate artery embolization cases. Dr. Lawson also oversees the prostate care program, with his center presently ranked among the top 10 institutes in the world, having performed over 200 embolization procedures. For more information, for those that would like to get the email addresses, we can go back to the slides at the end of the slide again for you to write it down. But for more information about Dr. Lawson's interests and clinical expertise, you can visit the websites that are listed at the end. So for now, I'd like to welcome Dr. Lawson to our presentation tonight.
Thank you very much, Aleta. And welcome, everyone. It's so nice to see such a big attendance. I hear we have a substantial Zoom attendance. And through the audio check, a very warm welcome to everyone streaming on audio via Zoom. For those people who are streaming, please feel free to, in the chat box, ask questions. I know sometimes it's easier to jot something down than in a live audience, put your hand up. It'll be very useful to take some of those questions during the Q&A sessions. A lot of what I talk about is going to be probably very new to you, so there will be a lot of questions. I expect to hear a lot of questions. I hope to answer them as best as I can. So once again, a very warm welcome. Thanks, Leta, to your team, to Mima for setting up a very nice presentation in the background. I hope you have a pleasant evening tonight. So I've been given the privilege of entertaining you for an hour. I'm going to try and do exactly that and make this a little bit entertaining, as opposed to listen to someone drone on about something. So we're keeping it between the hips and knees. A little bit of background. About 8 years ago, I had the privilege of standing up here and talk about fibroid embolization. And everyone listened and, oh, that's very good and fine. 8 years down the line, we've established a service in Namibia, and we've treated many, many, many patients with this condition, fibroids, through embolization. It's very successful, and we've had very good feedback, and our practice continues to grow. Again, a big thank you to Felvicia for making that happen. All right, so endovascular therapies for benign disease. That's a mouthful. All right, what does it mean? Anything that has an artery going to it, we try and target, we destroy the artery and cure the disease. It's effectively what it is, but we focus on endovascular arterial disease. That's the name of this topic. We're not going to look at endovenous treatment, staying in the veins. We're looking at endovascular arterial therapy. And we're going to look at two hot topics. One is BPH, benign prostatic hypertrophy. I'm going to stick to the abbreviation BPH because my tongue's going to roll over benign prostatic hypertrophy the whole evening. So we'll get to what that is in a second. And a very, very hot topic is this endovascular therapy for osteoarthritic joints. It's a great topic to talk about. It's really cutting-edge stuff. So let's go. Fibroids, you've heard me talk a little bit about. BPH, what is BPH? How do we approach it? How do we treat it? Where does an endovascular therapy come in? Is it even possible? How's it possible? And a little bit of the background to understand why we got to this point. And of course, osteoarthritic joints. It's nice and modern. What are we talking about? So what are the principles of what you're trying to achieve? All organs have an arterial blood supply. That's clear. So what is the concept of what you're trying to do? If you remove the blood supply to an organ, you arrest its growth or you induce cellular death. But that's counterintuitive. How can you then leave that organ inside a body part, inside a body? Doesn't make sense. I mean, you've all been exposed to what happens when a patient presents with a coronary event. It's a pretty fatal thing if it's a big artery. The chap dies, his heart stops. So how can you now go and electrically choose to block off an artery? What is the physiology behind it? What can you do to ensure that it's done safely, that it gives you the optimal effect, benefit for the patient? So what happens? Let's unpack a little bit of it during the talk. All right. So prostate arterial embolization. As the name suggests, we identify the prostate artery. We do embolization. Embolization is the introduction of an agent into an artery to block the blood supply to it. It's a big word for saying cutting off the blood supply to something. Lots of ways of doing it, and we won't go into too much of the technical detail, but you'll very quickly see what it's all about. All right, so what makes BPH, benign prostatic hypertrophy, a little bit different to, say, fibroids? The patient has a fibroid, she's symptomatic, we embolize the fibroid, she gets better. Cause and effect. BPH is a little bit different, as illustrated by these three yellow little circles. It's a slight overlap of a few things. So a patient, let's be clear, there's only men who get BPH, yeah? No. Please, let's just be clear. And it's older men, okay? So I'm approaching middle age. So I'm staring at the bullet train heading towards me. But there's an incredibly high incidence of BPH, okay? Another thing, it's not cancer, please, okay? Benign. I mean, the words are here, benign. So this is vital, and I'm going to emphasize this. We are not talking about cancer here, so forget it. So it's got to be a boy. He's got to have non-cancerous enlargement of his prostate. Now we're going to start talking about this BPH thing. All right. But just because you've got a big prostate doesn't mean you're going to have symptoms that need embolization, endovascular therapy. There are other things that can mimic the same kind of trouble, the same symptoms. And this is vital. I'm going to just mention a few of them on the right-hand side of the screen. So let's go to what a bladder outflow obstruction is. What could cause it? Yes, benign prostatic hypertrophy. And let's just go through some really basic anatomy. Bladder, prostate, urethra. Anything around the prostate area or at the bottom of the bladder that causes a narrowing and stricture, anything, is going to cause difficulty in urination. All right? But it's not always the prostate. It can be something else. Now, if you're going to do endovascular therapy for something which is not BPH and it doesn't work, well, you've got the wrong diagnosis. You must be sure of your diagnosis. Is your BPH causing your obstruction? Yes, it is. Give them the right treatment, give them the right therapy, and your patients do well. So this means that you have to work hand in hand with a urologist. I'm not a urologist, but I'm an interventionist. So I can navigate my way around the arteries of a prostate, but I don't necessarily have the clinical acumen that a well-tuned urologist would have in diagnosing and managing BPH. So we have to work together. We have to understand the physiology, we have to understand the anatomy and the pathology behind it. All right, so if you've got an active infection, you've got a cystitis, it gives you symptoms of BPH. But don't embolize that. Treat the disease and diagnose the right disease. I'm not going to go through each and every single one, but the point is you can see there are a whole bunch of things that can mimic the symptoms that BPH could produce. So we want to make sure our diagnosis is right. This is a very important slide because the urologists have only a certain size armory with which to treat BPH. Now, I'm not going to put this particular slide up because it's overwhelming. There are close to 15 or 16 different strategies to treat BPH. Now, when you have so many strategies to treat a pathology, not one of them is going to work better than all the others. So it's a bit of a hit and miss, right? So let's have a look at what the urologists do most often. Patient comes in with BPH, he's made the diagnosis, the patient doesn't want any form of surgery, so we use medical therapy. Have a look at some of the side effects. A lot of the practitioners here, I'm sure, are familiar with the drug Flomax or tamsulosin. Yes, it's like giving Smarties to patients with BPH. It's a very common drug that we use, very effective in a group of patients, but look at those side effects. And those are pretty unpleasant side effects. And we're not talking about 0.5% of patients who get side effects. It's a very high incidence. So now you have a patient with BPH, you're giving him a medication which will make his life a bit better, but then the side effects are intolerable. What do you say to the patient when he can't accept these side effects? Look at the Duodot, the agent in red, erectile dysfunction. Now, thoroughly unpleasant, when your whole life everything's worked fine and now you can't get it up. All right, that's not good as a side effect. You can urinate now, but you can't get it up. So your quality of life starts going down. Your loss of libido, the two go hand in hand. It's a miserable side effect to have from a medication. So it leaves the patients in a conundrum. This is what they can then get. Now you have a patient who's got BPH. He's, say, failed his medical therapy, and now he's faced with some surgical options. Now, most men, when you say to them, we're going to introduce a camera through the urethra into the bladder, through the prostate, and then turn on a switch which is going to bore your prostate out, most men don't find that particularly appealing, unless their symptoms are so severe that they will take something with a very high morbidity. So make no mistake, in the age-old TURP, the TURP is a transurethral resection of the prostate. It was developed in the early 70s, late 60s. Literally, it's the mechanical boring out of the prostate. It has a 30% morbidity rate. So morbidity is not a death rate, it's complication rate. Bleeding, retrograde ejaculation, erectile dysfunction, infections, and you just name a few, all right? But it's the main line of surgical therapy that urologists have for patients with BPH. But there's another problem with it. It's only good for a certain size prostate. Once a prostate exceeds a certain size, you cannot do TURP, which means you're faced with the third arrow in the quiver, and that is an open prostatectomy. Again, as the name suggests, a low cut on the abdomen, the prostate is literally cut away. So you can imagine bladder, prostate, urethra, cut off prostate and join bladder and urethra. It's fraught with morbidity. Of course, it gets done very successfully. Please, I'm presenting to you a slight bias because I'm promoting prostate artery embolization. But the point is, the solutions out there for patients with BPH can be rather aggressive. Excuse me, I'm just going to have a sip of water. So let's have a look at who gets prostate artery embolization. So again, it's very important that we work with a urologist that is willing to, number one, accept the concept of embolization and is willing to learn about which patients will do best after embolization. So a full clinical assessment is vital. Moderate to severe LUTS is the urology term for lower urinary tract symptoms. Lower urinary tract symptoms, difficulty in urinating, difficulty in starting to urinate, difficulty in ending, dribbling, nocturia, waking up at night, inability to start, inability to pass, recurrent infections because they can't void the bladder. So you've got what they call a high residual volume. The man goes to the toilet, he empties his bladder, he feels that it's sort of empty, but when you scan him, an ultrasound scan, you see the bladder is still full of urine because the bag simply can't empty. So these are all LUTS symptoms. Moderate to severe, and we'll talk about the scoring system in a second. So this next value is fairly important. Prostate over 60. So the South African Urology Society advocates not to do a TURP, transurethral resection of prostate, in prostates much over 60 grams. 60 mils, 60 grams, much the same. Why? Because the bleeding becomes unacceptably high. So when you're in there with a camera boring away at the prostate, obviously there's bleeding. A very big gland is very vascular. So the bigger the gland, the more vascularity, the more bleeding. Now you can't control bleeding through the scope of a camera. So what do? You do a suboptimal prostate resection and get suboptimal clinical results. So that's why they put that suggestion out there. Don't do a TURP over 60 to 70 grams. So you have to do something else. What do you do? Now, there's a whole slew of surgical procedures that you can potentially do, but there's also then the open prostatectomy. The point is, it's this category of patient that we look at for prostate embolization. The symptoms might not be that bad that a patient want or accept open surgery, but the patient is still symptomatic enough to want something done. They've potentially failed medical therapy, or the medical therapy side effects are intolerable. So now we're talking about prostate embolization. Again, PAE, please bear in mind, this is just another string on your bow in the armory of managing BPH. It's not the answer, to all BPH, but done properly in the selected patients, it works extremely well. So, proven bladder outflow obstructions on urodynamics. Now, this is a tough one because what is urodynamics? So in South Africa, it's a 5,000 Rand exercise where a pressure monitor is placed up the patient's backside and into the urethra, and the patient's asked to urinate. Okay, it's expensive, it's not that comfortable. And can those results be made clinically by a good urologist? There's a lot of argument here. It's very nice to have a urodynamic study. What it does, the next picture should show, we'll get to it in a second, is it tells us whether the bladder is working. There's no point in making a hole in your prostate and the bladder, which is the pump, and this is pure physiology. Bladder full of urine, pump, squeezes, urine exits through the urethra. It doesn't help that the pump is not working. So the UDS is designed to work out whether the bladder is still working or not. It's a very expensive investigation to add on to potentially another expensive procedure. In our practice in Johannesburg, we don't do UDS routinely, as with many centers in the world. It's a nice extra, but there's a cost involved. All right. Obviously, someone who's in acute urinary retention, why do they go into acute retention? That prostate has just got too big, it's squished off the bladder neck, and now that patient needs a catheter. So what do you do with the patient? It's a very vascular prostate. You don't necessarily want to go and interpret the patient. Offer them prostate embolization. All right, so let's look at who we're going to exclude. This is very important. There's no age exclusion. All right. As long as the patient is symptomatic BPH, whether they're a 50-year-old man, whether they're a 95-year-old, come on, there's no point in doing a procedure on a 95-year-old bedridden man who can't even go to the bathroom. So, I mean, within reason, there's no age exclusion. The smallest of small prostates, again, you can imagine small prostate, small blood supply, big prostate, big blood supply. So if you have something particularly small, your blood supply might be quite small. So why go for that for embolization? You need a vessel to target. As we've said, if it's malignant, we don't touch it. There is a branch to this where if it's a low-grade malignancy, we might, but that is for a Q&A session afterwards. Severe atheroma. Now, BPH doesn't occur in young people. It occurs in older people. What happens if you're 50, 60, 70? You've been exposed to 70 years of life. You might have had diabetes. You might have hypertension. You just might be old. Your blood vessels become tortuous. You get atheromatous deposits. If it's severe enough, the blood vessels that we're trying to target, you just simply can't get to. And we'll go over the technical thing about this in a second. We mentioned bladder failure. If the pump doesn't work, there's no point. It doesn't matter what you do to the prostate. It's just not going to work. Chronic urinary retention. So if someone's been sitting on a catheter for goodness knows how long, that bladder is never going to work again. So it doesn't matter if you open up the prostate or not. Severe renal dysfunction. Again, if they're end-stage renal failure, there's nothing you can do about it. If their kidneys are sort of marginal, there are strategies that you can take to give them a chance of exposing them to iodine, because during the procedure we use iodine, and in theory, iodine can compromise renal function, so you don't want to necessarily do that. And then last, bladder diverticular. So just to mention here, bladder diverticulum is an extra lobe on the bladder. It fills up with urine and becomes a focus of stasis. So again, the bladder diverticular doesn't empty the urine. So it doesn't help if you've opened up your prostate, but the bladder is full of urine if stuck in the diverticulum. Again, fix the diverticulum, then do the prostate. All right, so let's have a look at how we work a patient up for PAE. We exclude cancer, basic PSA, digital rectal examination. That's a good start. Transrectal ultrasound is the QRS, biopsy if necessary, and a multiplanar MRI if needed. Now, we certainly don't do all of this in our practice. A patient might come with the MRI. They certainly have a TRUS, transrectal ultrasound, a digital rectal examination, and a PSA. That's considered an absolute standard for excluding cancer. All right, let's have a look at how we're going to score some of these patients. Now, the Urology Society has developed a very nice symptom score. when you say to someone, how bad are your symptoms? You're going to say, well, doc, it's pretty bad. That's a bit useless when you're trying to write a scientific paper or when you're trying to do a comparison. It's nice to have a score. So the International Prostate Severity Score has been developed. It's 7 or 8 questions, 0 to 5, a total score of 35. I'll show it to you in a second. You know, if you score low on it, then you've got low symptoms. You score high on it, high. But importantly, you can now say anyone who scores over a certain value, these should be considered for embolization. And more importantly, when you follow them up, they scored, say, 30 out of 35 pre-embolization. After embolization, they're scoring 5 out of 35. It's a nice objective way of testing ourselves and ensuring that the patients get a good level of care. The International Index for Erectile Function, again, very useful. So how's your libido? It's okay. How's your erectile function? Don't know. A nice scoring system's been attached to it. Now, this is vital because one of the issues with TERP and PAE, TERP has got a high incidence of erectile dysfunction afterwards. PAE almost has no impact on erectile dysfunction. If you can show values and you can prove scientifically that your values are significantly or statistically significant, now you're onto it. But you can't do it subjectively. You need some form of numbers, and that's what the score gives you. All right, we spoke about our urodynamic study. A CT angiogram is vital. So a patient has checked all the first 3 or 4 boxes, and now we come to a CT angiogram. What is a CT angiogram? We've got a wonderful ERAD facility over here with a nice fancy scanner. The patient goes through a CAT scan, he gets iodine injected into his veins, and we get an angiogram, an arteriogram. We get a look at his arteries. This is vital. It excludes atheroma, and it shows us as the interventionist, where are those prostate arteries? Why? We'll have a look at the next few slides and we'll make it very clear how difficult this prostate artery is. The graph on the right just gives you an idea of this is what it looks like on a UDS. The green, someone who can urinate nicely. The yellow, a bit of an equivocal UDS. And anyone who falls in the pink band is clearly obstructed. International Prostate Symptom Score. I'm certainly not going to go through this in detail, but we spoke about the quantitative way of assigning a figure to someone's symptoms. 7 questions, 0 to 5, what do you score? Very useful. You score high, you're a candidate for embolization. You score low, you're probably not. And the one at the bottom is quality of life. A very useful thing. It's 0 to 6. 6 is terrible quality of life, and it's a purely subjective question. How are these things affecting your life? So let's have a look at some of the data out there. This is again very important because you can't have someone do prostate embolization in any little shop, in any little hospital, anywhere. You want to make sure that there's comparable outcomes across your different centers, which means people have got to be appropriately trained, patients got to be selected properly, and the job needs to be done well, particularly when the new procedure is coming into light. Make no mistake that BPH is very new. The oldest data or the oldest patient out there, I think it's 15 or 18 years after the procedure. So it's still very, very, very new. So we need to make sure that everyone knows how to do this. Patients are selected well and technically done well. So let's have a look at this first graph. IPSS is the International Prostate Symptom Severity Score. Look at the 2 centers. Look at these 3 centers. And the reason I put them up there is pretty important. This UHS, the first one, that's where I trained, University of Southampton, University Hospital of Southampton. They ran the rope trial, which we're going to talk about in a second. So vital, because they are the first time PAE really landed in Europe. If you look at Brazil and Portugal, like, why are you putting Brazil and Portugal up? Well, the archetypal grandfathers of PAE come from Brazil and Portugal in the form of Francisco Carnevale in Brazil and I've just forgotten my mentor's name in Portugal. The poor man unfortunately had a large cardiac event at one of the radiology conferences a few years ago, and he's no longer with us. But these are doyens in the world of creating and bringing to light PAE. Now look at that graph. Across all 3 centers, you have the same trend. There's an improvement in the IPSS. So that's 3 centers, 3 different countries, all pioneering PAE. Quality of life is the next graph. QOL, quality of life. All 3 centers show a nice decrease after PAE. And last but not least, second last is the peak urinary flow. The deep purple is 12 months after PAE. The light purple is the baseline. The deep purple showing an increase in flow rate. It means the guys are urinating better across all 3 centers. Prostate volume, similar outcome. All right. Now, here's the touchy one. Do we compare prostate artery embolization to TURP when we've just said that we're doing prostate artery on patients with slightly larger glands? So this is a very contentious topic. The American Urology Association is very against prostate embolization. They feel it's a big turf war, that we're stealing their work. We say, well, guys, if you are comparing prostate embolization to TURP, you could potentially look at a turf war, but let's look at a cohort of patients with large prostates who aren't even TURP candidates. So, I mean, you appreciate the nuances in bringing something like this to life. So let's just have a look at PAE versus TURP without the turf war in it. So what do you see? We're looking at the symptom score. There's a drop-off on the blue line. Look at PAE. There's a significant drop-off in the symptom score before embolization compared to after embolization. Look at TURP, another big drop-off. And the yellow is, and the yellow is medical therapy. There's pretty much a stable, nothing much happens with medical therapy. Prostate volume, look at the red line. There's a big decrease in prostate volume with TURP. There's a moderate decrease in prostate embolization. Quality of life, again, you're seeing the trends, but you're seeing quite a big change with TURP. So why am I showing this now? You're saying the TURP is much better than prostate embolization. Well, there are good things about it. We're not trying to put TURP down anyway, but there are certain differences between TURP and PAE, which makes comparison a little bit tricky, but there are also certain negative things. But let's look at the place of UAE. Let's look at the place of PAE. And this is vital. We want to see where PAE fits in the management of a complicated condition. All right, so let's scratch back at our anatomy. So when you were back and studying anatomy and into the medical world, you have the aorta come down, common iliacs, internal iliacs, and then there was lots of stuff in the pelvis, which we didn't quite really know about. I can't remember learning all these funny branches. But unfortunately, when you do prostate embolization, you have to unpack the internal iliac vasculature in great detail. So the first time I saw this image, I thought, I'm not going to do this. And this is too much for me. And then I saw this and it became even worse. So this is a reconstructed CT angiogram. So someone very kindly put a patient through the scanner, gave us 800 megabyte file and reconstructed and said, find the prostate artery. It's like, you've got to be kidding me. I mean, it's a mess. So we've labeled a few things rather obscurely. SG is super, this is the fun part. We're going to show you a few fun slides to see what we faced with when you start out this. So remember, the guys started working out, I mean, the prostate artery didn't exist. It was called the inferior vesical artery way back in the day. So when Carnevale and Pisco, he's the man in Portugal, thanks for coming into my head again, they worked out the anatomy of pigs, and they had to orientate their radiation machinery to get the best view so we could get to these arteries. So this was darkness to them. And so now you're learning it, but they've already shed light on it. Have a look at that left PA off OBT. Look where that green arrow is pointing. I mean, you can barely make out a little white stripe going to the left here. That's a 1.5 millimeter diameter vessel that you have to target. And you've got to go through this kind of stuff to get there. This is a slightly more friendly one. Anterolateral PA, left DOM. Okay. So these are the words that we use to try and orientate ourselves in the pre-procedure planning. Okay. So we reconstruct the images to make us feel better. So when we get to the patient doing the angiogram and we see a leash of rubbish, we at least have a roadmap. So we don't spend hours trying to find it. All right. These 4 pictures are very pertinent. Let's give you an idea of what we do during the procedure. All right. We use a catheter. Now, everyone has seen a catheter. Everyone's medical. You've seen Foley's catheter. You've seen all these. All right. But we use very small catheters. We use 4 French or 2.4 French catheters, about 60 or 90 centimeters long. That's that long. All right. So let me give you an idea of the physics behind this. If you push a catheter in a pipe, in a straight pipe, it goes where you want it to go. That's logic. You put 190-degree bend in that pipe. Now you're pushing the catheter. You lose 25% of its maneuverability. Okay, you with me? Each prostate artery has got at least 4 90-degree bends in its approach. So 4 times 25, you do it. You've got no control over that catheter tip when you get to the prostate artery or get close to it, which means a number of things. Number one, the operator has got to be competent, but number 2, the guys who make the catheters and the little wires that we use to get there have to produce state-of-the-art equipment. Because there's no way you can take a pipe, bend it 4 or 5 times, and expect it to go where you want it to go. So there are some wonderful products on the market that allow us to negotiate this stuff. I mean, look at the white on this. My cursor, is my cursor showing there? Can you see my cursor? I can see it here. Can you see a cursor on the screen? No, no cursor on the screen. So I'm going to step up for a second. You take a straight catheter. You introduce it into the groin here. You put it to that point. There's one bend, another bend, the third bend. You haven't even crossed over the top to the left side where there are a few more bends to find the prostate artery income. So it puts an incredible demand on the people who produce the hardware that we use. So the stock standard catheter that we use to get to all of these things, that'll set you back 10 grand. So the minute you open the box, it's 10,000 rand that we spent on the patient. So you drop it on the floor, it's an expensive affair. You can't get into the artery with it. You've got to reach another one. It's another 10,000 rand. So you've got to be careful at how you spend your money, because this procedure can get prohibitively expensive. Inappropriately trained operator, the cost is a blank check for the medical aid. Why do I mention this? I'm sitting in a private hospital. All right, so it's vital to understand what we're trying to do and stay within our costing model. All right, so great. We've got to the prostate artery again with lack of a cursor. I'm getting settled at 40. 1.5 millimeter diameter vessel. This little thing over here is a 2 millimeter catheter. It's taken a bend until the front and gone into a tiny prostate artery. This is magnified fourfold. All right. In reality, that's 1 to 1.5 millimeters diameter. When you reach that point, you inject iodinated contrast and you ask your machine to do what we call a cone beam CT. So this is a vital thing, and I'm just going to mention it now. I don't have a dedicated slide to it, but we're here and everyone looks nice and brightly awake, and we've got lots to talk about. So during the procedure, the angio machine that we use spins around the patient, and it generates what we call a CAT scan. Right? This is the CAT scan image. I mean, everyone in this room has seen a CAT scan. Doesn't that look like a CAT scan? So the patient's left the bed that our facility has given us the CAT scan image. If you look over here, this white section over here, it looks like half of something else. Am I right? That half of the prostate is enhanced with iodine, with contrast. So that tells me that when I inject my embolic agent, the thing to block the artery, that is what I'm going to kill. Safety. What are the neighbors of the prostate? It's the bladder, the rectum, and the penis. You embolize any one of those three, and you're going to have a very unhappy patient. Right. Let's go back to the rope study. So I mentioned those first few graphs, the University Hospital of Southampton, where I had the pleasure of working. You'll see the name at the end there, Nigel Hacking. He was also in this hospital when we started fibroid embolization as a bit of a come and talk and promote it. He's a lovely guy. He's my direct mentor with PAE, and I've got huge respect for him. So he drove this ropes trial. What is it? The efficacy and safety of PAE for BPH, an observational study, propensity matched. Now, statistics, we'll leave that to the statisticians, comparing transurethral section TURP of the prostate and PAE. All right. This was really a landmark study because number one, it came from Europe. No one wanted to believe the Brazilians or the Portugals, guys from Portugal, but they'd believe something that comes out of a reputable, dare I say, European hospital. And this was one of those landmark articles that really changed the face of PAE in the world. So what does it say? PAE is clinically effective. That's wonderful. Okay. How effective? Is a 10-point drop in the IPSS. So let's say a patient started on 30 out of 35 on his symptom score. On average after PAE, that would drop to 20. Bear in mind, severe is over 30 and considered moderate is about 18 to 20. So we move them categories. We take patients from severe to acceptable. IPSS and quality of life improvement. Now, this was interesting when you start reading about new techniques. The first thing you're trying to do when you bring a new technique to the world is go, well, is it non-inferior? It's inferior or it's not inferior. There's this lovely statistical phrase, non-inferior to TURP, and that's vital. So the first thing is to say, are we doing anything worse than the current accepted gold standard? No. So that's really important. It's not worse. Okay. Statistically significant, that's vital because everyone understands this. This was published in the British Journal of Urology, so it's a accredited, acceptable, a fairly high impact journal, particularly in the world of urologists. There's an improvement on maximum flow rate and prostate volume. These are good things. Finances. Most patients, well, single day cases. Very important, no hospital fees or minimal hospital fees. 80% of TIRF cases require at least a night in hospital, with the majority requiring 2 nights. So we also want to have a cost-effective strategy. There's no point in saying, guys, we've got this wonderful PAE, but it costs double a TIRF. That's not going to work. You want something that's new, works, safe, and cheaper. All right. I'm going to share, when I put this presentation together, I grade these out because the results weren't out yet. They're out, and you'll see where this came from. I'm going to run through this because we're going a little bit into time. So you ask, who pays for PAE? So we went to Discovery and said, listen, this is what we do. And they said, look, guys, it's great, but it's not considered mainstream yet. And I said, well, would you be interested in doing a pilot project with us? And they agreed. So Discovery Medical Aid Scheme, I'm sure you all know of Discovery, it's the second biggest, if not the biggest medical aid scheme in South Africa, approved a pilot study under our care to see what prostate embolization would look like in South Africa. Which patients we treat? Do they do better? Do they get repeat procedures, whatever that is? What is the cost of PAE? All right. To cut a long story short, I'm going to put these couple of graphs up. We're now familiar with all of these things. Bear in mind the box on the right, this is a bit counterintuitive. Let's have a look at the first figure, figure 1, box plot, procedure and IPSS. The symptom score improved after prostate embolization, and due to our numbers and the work that we've done, we could show a statistically significant improvement. Each graph shows a statistically significant improvement in symptom score, quality of life. We then developed a questionnaire. So in private practice, you're limited by how much money you can throw at a problem. It would be ideal to bring each and every single patient back into the urology room and do a whole bunch of studies on them to say, this is what was pre-embolization, this is post-embolization. So obviously we didn't have that kind of money, no one has. So we developed what they call a PROM, again, an internationally accepted standard, patient-related outcome measures. A few questions to ask a patient to see whether that patient is happy with the procedure. The details are on. All right. So we showed, again, a significant impact on the PROM score. With other words, patients were happy. And that's what you want. You want a happy patient who's had no complications and who's had biggest bang for his buck. Discovery has approved the green light to roll prostate embolization out as a benefit package for BPH in South Africa. That's big because it's got a huge impact on what happens in sub-Saharan Africa. Because everyone, our neighboring countries, look down at South Africa and go, well, what do you pay in South Africa? Medical aid pays for this, and you've seen it here. Medical aids here will start paying for mainstream things. All right, Discovery have now approved PAE in South Africa under a certain range of conditions. So the next medical aid group will start going, well, Discovery's approved it, we'll approve it. It's a landmark victory in the world of intervention. Lots more to talk about, but I think you've had a lot of information. We're going to touch on need. So before we go to need, have a drink of water. I certainly need one, but I'd like to take some questions. So,
I've seen a lot of patients in post-embolization symptomatic caused by hypertrophy.
yes.
So if a patient also develops symptomatic post-embolization prostatic calcifications, how do you manage those?
So that's a good question, because by definition, an organ that is calcified has infarcted and is dead, and theoretically shouldn't be symptomatic anymore. So fibroid calcification, prostate calcification are a little bit different. So let's talk about prostate. We're just sitting on prostate for now. Prostates get inherently calcifications that form in them. No one knows why. It just happens. So we haven't seen any calcifications which have developed in the prostate after embolization. The patients who do come back symptomatically, and make no mistake, PA is not the magic bullet. We have a 20% non-clinical response rate. Those patients have required a secondary TIRP, at least. A few patients have required a secondary embolization, but really there hasn't been such a big time between that and the calcification that we've seen. Yeah.
Three questions.
Excellent. Let's take one by one.
One, just the pathophysiology, because you have a urethra, you have the prostate that's large,
Yes.
causing obstruction.
Yes.
You kill it.
Yeah.
How does that improve the
So this is a fabulous question because the corollary of that is, why don't we do embolization for malignant prostates? Very simple. So in theory, practically malignancies in a prostate generally occur on the peripheral zones. So during our procedure, we can often identify the arterial supply. There's a peripheral arterial supply and there's a central arterial supply. But you don't see it often enough to say, well, we can put beads down there to destroy malignancy. So we don't see that enough. So we can't say we can treat malignancy. It's in the peripheral zone. But the central zone, which is around the urethra, that we get to 9 times out of 10. And it's phenomenal because even though the overall size of the prostate might not have decreased that much, the bit around the urethra that is causing that compression, that resolves and decompresses the pressure of the urethra because we target that central arterial supply. Does that answer that?
Yeah.
Good. Excellent. Now, second question.
Question. Side effects, because you went deeply into everything that goes wrong with the therapy, but then I'm sure there's complications.
Excellent. That's a very good question. I'm going to answer with less than 1%. So again, we're looking at trained operators and centers who do this regularly. All right. So what are your potential complications? There's regional and local. So regional is we're going through the groin, we do an angiogram. So any potential complication there, hematoma, infection, it's rare. Nowadays, it's really rare. We use very small French access systems. So that's super rare. The procedure itself, who are the neighbors? It's bladder, rectum, and penis. Now, in the old days, when they started this, we didn't know what size embolic, and I haven't even spoken about the embolic agents, the thing that you put in to block off the artery. We haven't even spoken about that. But in the first trials that came out, the size of the agent that they used was too small. So the neighbors got damaged. Penile shaft, penile glans ischemia, bladder ischemia, rectal ischemia, miserable, unpleasant side effects. But nowadays, the type of agent has been refined and the size has been refined. So all those fall under the 1% category. ED, erectile dysfunction, that's a very important one. It almost doesn't happen after embolization. Not that it doesn't happen, it's very rare. Certainly compared to TIP, it's very, very rare. And those really are the biggest complications. Now, the urologists argue and say, you've infarcted a prostate, that's a nidus for abscess formation. Man, that is rare. It is so rare, it is unbelievable. It is very, very, very rare that a patient who's had prostate embolization has developed an intraprostatic abscess that's required surgical drainage. Do they get an infection? Yeah, sure, they might, but it's treated conservatively and responds conservatively. And that's not common either. It just doesn't happen. Question 3, these are good questions.
Cost.
Cheaper than TIP. Yeah, about 20% cheaper than TIP.
The procedure itself. Cheaper.
Everything, the package,
The package.
the entire package. Exactly. And this is vital. I've been critically involved with the costing of PAE. It's no point in saying, well, the PAE costs 20,000, but the ancillary things cost another 100,000. So we've developed a package price that includes the professional fee of both the interventionist plus the urologist, the CAT scan, the hospital admission, the theater usage, the consumer usage. And in our presentation to Discovery, we disclosed all of these things. And even then, it was favorable in the form in the interpretation of the funders. But we also had ourselves to a very high standard. You can't just take 3 little catheters off the shelf and 10, 20, 30,000. You can't say, well, that scan was rubbish, so let's repeat the scan. So we ensured that whoever we used as our service providers were, I can't say accredited because that doesn't quite exist, but were skilled in what they were doing and were ethical in what they supplied us. So that's how we could keep that cost within reason. We certainly weren't more expensive, but about 20% under the term. Yeah. But yes. Oh, let's take him and then come back. Yeah.
Okay. About 20% of these patients make their therapy.
So when is that? Mainly failed.
Yeah, it didn't work so terrible.
No, something else. So no, it's open surgery, open prostatectomy. So they would either go to TIP or they would have to go for open prostatectomy. Yeah.
Now the other 80%, how long till they'll need something like?
How long is a piece of string? Because the oldest data is only 18 years old. You know, when you compare TIP, the TIP was designed in the 70s. So you've got 50 years worth of data coming out. So PAE is still young. So we've been doing PAE now for 8 to 9 years, and we've had 4 or 5 patients who have now needed either a repeat TURP or have now had symptoms coming back that they now needed a second procedure, be it a TURP or an open prostatectomy. So, yeah.
So basically, if you go to PAE, the question is that the end of the road, or you still need maybe something?
You
else?
may need something else on the road, but is that 2 years, 3 years, 5 years, 10 years? And we'll put it this way, to have a repeat PAE is not a problem. Having a repeat TURP or having a TURP in the first place, that itself can be quite uncomfortable. So, as I said, it's not a magic bullet, but when you're facing, as a patient, that decision, can I avoid a TURP for another 5 years? Most guys are going to say, yeah, I'll take that. I'll take that. It's just money.
My second question is, how many times?
As long as the prostate artery is visible on your pre-procedure CT angiogram. We've only done it twice on the patient before. We've never done it more. My colleague in the UK, Nigel Hackman, my mentor, has now started putting additional embolic agents in, which means now that's going to be a bit difficult to ever repeat it. So the verdict is not quite out on that and what you should do. So
You can return that.
absolutely, absolutely, absolutely. Yes.
Duration, that's the last thing.
Of the
How long
procedure?
does it take?
60 to 80 minutes. Yeah, wide awake, day case, pain-free, go home the same day. Yeah, absolutely. Nothing, nothing, totally pain-free. Yeah, totally pain. All right, so it is how are we doing for time?
If you embolize benign prostate, would it then reach the biggest?
That's a very good question, because quite a few patients have come to us and said, listen, you know, sometimes I'm not so bad. We say, why do you want treatment? We said, well, if I've got less prostate, there's a less chance of me getting cancer. You know, I don't know. I mean, we obviously tell them we don't think that's the case. Is that the case? I don't. It sounds nice. It sounds nice, but the verdict certainly isn't out on that. I think, shall we say, from the scientific community, what they want to know is, can early cancers still be detected in someone who's had prostate embolization? Because when you do embolization, you infarct parts of the prostate. And what happens if you partially infarct a piece of cancer and now you're doing your PSA and your PSA is factitiously low? And the feeling is you can still safely screen for malignancy after PAE. That's sort of the take-home message at the moment. And that's sort of a very important question to ask. Can you still screen for it? Because the minute you repeat PSA after PAE, it's through the roof. And then after a few months, it settles. It goes way down. And then what happens when it starts rising? Is it malignancy or is it just BPH growth again? But at this point, people have accepted that you do embolization, let it be, you can still continue your cancer screening protocol. All right. And that's how we're doing. We're good. All right, guys, we're not going to put you through such a grueling session with knee osteoarthritis, but remiss of me to not talk about this. This is really cutting. Oh, yes.
Can you use this in conjunction with your medical therapy, or do I stop the alpha blockade?
That's an excellent question. That's vital, because why do we do PAE? We want to get the patient back to his best baseline as possible. If they're coming to you on medical therapy, combined therapy, triple therapy, dual therapy, and they're having side effects, like, doc, I don't want to swallow a box of Smarties every morning. Our goal is to get them off. So in our practice, for the first month after PAE, we will stop the basic things like Flomax. We keep them on Flomax the first month, but thereafter we taper it with an aim to stop it completely. So our goal after PAE is to get patients off their medication. Of course, you can keep them on it if the PAE hasn't been as good as you like, but then you hope that the side effects of the medications aren't severe. But if you have someone who's coming to you saying, I can't handle these side effects, your goal is to get them off those meds, because you don't want to have them do PAE and remain on medication, which is causing them unpleasant side effects. Yeah, but we certainly want them off.
So,
yes.
What is the risk of, rectal stricture after PAE?
Fortunately, zero. It's zero, because we don't go anywhere near the urethra. and the vascular supply, and again, this has been proven repeatedly by academic centers that have scoped the prostatic urethra after PAE, it remains pink and unmolested after these procedures. So there's been no record of a urethral stricture. Having said that, if you are urinary catheterizing the patient for every PAE procedure, obviously there's going to be a risk of urethral stricture because of potentially aggressive catheterization, depending on what catheter you use. We don't. We just don't catheterize our patients. So from the procedure itself, urethral strictures don't happen, but obviously if you start manipulating the urethra, you have a stricture or risk of a stricture. Yes.
If somebody has PAE first and then afterwards they want to open surgery, are there any issues with regard to the healing after PAE?
Let me answer that with a funny story. So I do all these procedures with the urologist together, and the embolic agent that we use comes in colors. And we always get the yellow balls ready, because they're tiny little 250 microgram yellow synthetic spheres. So they mix up the yellow balls, and we do the embolization, and then we feel for whatever reason we need to upsize the balls because it's a slightly bigger vessel, and we'll inject the green, the blue balls. So we inject the blue balls. And so my colleague says to me one day, what happens if you mix the two? I've got no idea. You know, you mix your primary colors, what happens? And we were joking. Oh, 6 months later, he does a TERP on this particular patient. And the mixed color came out. The green color came out as the yellow and the blue all mixed together. And he answered the question. So I thought it was... So in answer to your question, doing a TERP, let's focus on a TERP first. Doing prostate embolization on a patient who potentially will need a TERP reduces the risk of TERP bleeding immensely because you devascularize the central part of the gland. So here you have a guy who's got an 80 or 90 gram prostate, not suitable for TERP at all. You do the embolization, and for example, there's a thing called a middle lobe in the prostate. The prostate's got a left and right, and sometimes, unfortunately, there's a big middle lobe. After embolization, that middle lobe sort of collapses a bit into the urethra, into the prostatic urethra. The urologist can now go in and safely resect that middle lobe, which you would not have been able to do pre-PAE. So it's devascularized. Open prostatectomy, same kind of thing. You've devascularized a big part of the prostate, so you've got less bleeding. But the issue with open prostatectomy, not so much as the bleeding, it's the issues related to removing the prostate and how much neural damage you do. The bleeding really comes from TERP. So doing a TERP on a big gland, too much bleeding. Doing a TERP on a big gland after PAE, much better. Yeah. As long as you get your color mixed right in the balls. All right, so the Japanese guys, again, developed this. They said, look, what do we do with patients with intractable inflammatory arthritis? Shoulder, elbow, hands, knees. Let's try and embolize them. So I mean, again, in your practice, I'm sure you've seen it ad nauseum. You have patients who've got arthritis, rheumatoid arthritis, and they're just burning holes in their stomachs from the amount of NSAID use. All right, so what do? You inject them, you do all sorts of things. But what happens if you embolize arteries going to those inflamed joints? And the Japanese opened this Pandora box, and they said it works. So they got a lot of their patients with these really sore shoulders, embolized them, and patients started having pain relief. All right, what happens if we redirect to something which is an international phenomenon, osteoarthritis of the knee? Why the knee? It's a big joint. We can get to it endovascularly fairly easily. What happens if we block off those arteries? Will our patients with knee osteoarthritis get any relief? Now, this is a vital concept. Fibroid embolization, effectively a cure for fibroids. That's nice. Prostate embolization, a really good treatment for BPH. Not a cure, but a very good treatment. Geniculate artery embolization, geniculate artery of the knee, is a temporizing mechanism for someone who's got osteoarthritis. Temporizing, not curative, just to help them with the pain. Again, in your practice, you would have seen these people come in with crutches, long-term steroid abuse, damn sore knees, but the orthopod says, you're not ready for a knee yet. You're too young, you've got too many comorbid conditions, blah, 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 blah. All right? So what can you offer that patient? You've given them 4 or 5 cortisone injections, you've given them long-term local anesthetic injections, and they still have pain, intractable pain. You want to offer them something. This is where geniculate artery embolization is starting to develop in place. What happens if you block off the blood supply? So, we've spoken about a few of these things already. I've summarized them all in one go. So, who gets geniculate artery embolization? What is geniculate artery embolization? Again, scratch back to your anatomy. You get a superficial femoral artery which goes down the leg to your popliteal artery, and you get 4 little arms that come off. Superior, medial, lateral, inferior, medial, lateral, and a few other crazy ones that go to the knee. So there are 4 vessels effectively that supply the knee joint. Geniculate artery, 4 vessels that supply the knee joint. So that is what we're looking at for geniculate artery embolization. Mild to moderate OA. We're not talking about someone who's got 0 cartilage left and just got bone on bone. Now, nothing's going to cure that pain. It needs a knee replacement. But someone who's got mild to moderate OA, requiring lots of NSAIDs, requiring cortisone injections, etc., etc. It's not severe enough to warrant surgery. Now, this is the important thing. I'm going to leave this slide up, and you're going to enjoy the slide if you can work it out. It took me a long time to work it out. So I'm going to walk you through the principles of what we're seeing on this side. So while you look at the pretty pictures, listen to what I have to say. You've got an inflamed anything. You get angiogenesis, neovascularization. Yes, you get an increased amount of blood flowing to whatever region, whether it's a broken bone, whether it's an inflamed joint, whether there's pus somewhere, there's inflammation. Inflammation draws chemical mediators to that site and produces pain. Yeah, we all know that. Anti-inflammatory drug, what does it do? It takes away the inflammation, and the inflammation going away, inflammation recedes, the pain recedes. But what happens if we do it on a more mechanical basis? What happens if we stop this proliferation of new blood vessels to that region? We block the blood supply to that region. We stop the angioneogenesis, neovascularization. Will that give you the same result? Looks like it. Genesis trial, when I wrote this, I started publishing Genesis 2 and Genesis 3. What is Genesis all about? Rather biblical connotation to it, but be that as it may. It's a prospective study looking at what happens when you do geniculate artery embolization. Again, I've had the privilege of working with this chap, Mark Little, at the Royal Berkshire. Young guy, enthusiastic. There's a lot of funding behind doing this. Osteoarthritis is a big thing in Europe. It's a big thing in the UK. It's an even bigger thing in the US. All right, so it's a very hot topic. Can you get people to be more pain-free and less drug-dependent? What did they show in the Genesis trial? Well, let's see what they did beforehand. I don't want to go too much over time. You examine your patient, you look at your X-ray, you look at your MRI. And what do you find? A picture of an MRI showing the 2 white arrows will indicate an area of synovial hypertrophy. Why is that important? Your synovium is the bit with the nerves in it. So it doesn't help if your bones are rotten. If your synovium and your cartilage are inflamed, these are the sites that interest us. Why? Because they will draw the increased blood supply. So what we do, and here we come to some nice pictures. Thank you very much to Jemima for putting up these nice blocks here. All right, popliteal artery, MC, medial collateral, LC, lateral collateral, and ghosted out in the image, because this is what they call a subtracted image. You look very carefully here. There's a tibial plateau. Here's one femoral plateau, another femoral plateau, ghosted out during this acquisition. Popliteal artery coming off. Now, somewhere in there, your target vessels. Your target vessels are also small, similar to prostate artery embolization, but your approach is much straighter. So this is a technically slightly easier procedure. But let's look at what we want here. Again, excuse me if I step up to the screen. This is a patient who's had a partial knee replacement that's got recurrent pain. This is what doesn't replace the joint. So it comes to the interventionist and says, what can we do? We've identified, let's call this a geniculate artery. That will be the down it comes to this area of the knee. Let's call this lateral compartment of the knee. And if you'll see all this black sand, this is iodine which has gone into the soft tissues around the knee. You can imagine with that much inflammation, increased blood supply, that knee is going to be painful. You embolize it by blocking off, not the whole artery, there's the reason behind that, just blocking off the stuff down. So they blocked it off. So do you appreciate all this grey mush over here? This has been taken away. So you've stopped all that neovascularization. So you basically infarcted what is going to cause the neural irritation. That's a good result, technically good result of embolization. The pain relief is immediate. Patients are wide awake. And the cases that we've done, the pain relief is immediate. Inject, stop the procedure is completed. You press on the bit that was sore before and press on the bit afterwards, and it's better. It's amazing stuff. So the results can be that quick. Patients will walk off the bed. They'll be crippled getting onto the bed and they can walk off the bed afterwards. Another little picture. Let's have a look at this. This is a nice little picture. All right. So got some labels. Name of a genicular artery. Might go to go see here. You see again, there's a lot of stuff running here anterior to the knee. Increased blood supply, increased neovascularization, angiogenesis, irritates the nerves. This black little spot over here is a microcatheter, which has been placed into the small vessel. We've injected with the little particles, spherical beads. Look at that. There are some little vessels going down, but it doesn't look anything like this. It's good enough to do the job. So what's the first question that comes on your mind? So you've just cut off the blood supply to the knee. You're going to infarct the bone, you're going to infarct the cartilage, and you're going to accelerate osteoarthritis. Genesis trial is showing that doesn't happen. A year after genicular artery embolization, the cartilage is intact and there's no bone infarction. Great. That's what you want to see. Because again, the side effects of this could be horrendous. Use the wrong agent, do it inappropriately, you can get some horrible side effects. You don't want someone who's now from going 5 years from a knee replacement to I now need a knee replacement because I can't walk what you did to me. So you have to be safe in what you do. Okay. It's having a significant treatment impact on osteoarthritis. All right. The current mainstay of treatment in patients who have arthritis is pain medication. Yeah, we all know that. There's side effects and there's risk to that. GAE provides us another string to our bow in managing it. It's not mainstream yet. It's being done in only academic centers. The medical aids aren't even looking at it at the moment, and it's yet to come into regular clinical practice. But this is gaining momentum faster than you can believe. Within the next couple of years, hopefully I'll be standing here saying thank you for endorsing GAE, because we're now offering it to patients. So this is where it's sitting. It's not one of those hocus pocus things. This is real. And why do I say hocus pocus? I'm going to mention one other thing. You might have heard of embolization for hemorrhoids, where people actually embolize one of the rectal arteries going down to the hemorrhoids. Sort of works. You might have heard of gastric artery embolization for morbidly obese patients. In the US, where they ran the trials, they spent years doing this. They tossed it out. Doesn't work. Not enough. So this is not one of those things. This is one of those things that you'll be seeing. Like BPH, we sit here, and I remember clearly one of the members of the audience asked me 10 years ago, 8 years ago, what happens if you embolize the prostate? I said, yeah, we'll come and talk in a few years' time. All right. Thank you very much for your time. Please, let's have a few more questions. We've gone over time a little bit, but I hope we've got
No, but the author board are here. It's fine. Okay, does anyone have questions? Oh. Oh, okay. All right. All right. Thank you, everyone, for attending the event. Thank you, Dr. Lawson, for the presentation. Very, once again, in a good introduction to the two topics, something to think about for our community, if I can say so. And I'm sure, I mean, as it pick up speed in South Africa, it probably will pick up speed here, and it will be introduced as an alternative for treatment plans as well, which always, that's always what happens between us and South Africa. Are there any further questions for Dr. Lawson regarding the prostate or the knee? Anything there? Okay.
If you're comparing it to a pacemaker,
It's cheaper, yeah. Yeah.
I mean, prosthesis will take you back 80,000 just there. If you don't use any prosthesis, you use expensive catheter, it's 10 grand. Catheter fee 25 grand. And that's it.
So if you start bringing it here, then
Theater.
Yeah.
But you need a cath lab.
Not for knee, not for knee.
Oh,
Not
for the prostate, yeah.
Prostate.
Yeah, for the prostate, yeah. Yeah.
Prostate knee catheter.
So once you have a cath lab, that's something you have to do the.
Prostate, yes.
Yeah.
But the knee you can do on our kind of machine.
So when you talk about they were able to leave their awake, you just do a regional block, the local.
Just go, we stick the sheath in, just a bit of luck and I would say, yeah, the normal angiogram, yeah. But there's no pain during the procedure, and there's no stress, not a stress thing for the patient. But we counsel them very well before we do the procedure, so they know what it is. But there is no fibroids, they can develop pain on the table during the procedure, and tend to keep them a little bit more sedated. Even that can be all right.
Cool. All right. So thank you once again, everyone, for attending. Okay, just to announce, our next topic will be held on the 3rd of July, held by Mr. Last Chitumba. The title, the title will be The Role of First Trimester Ultrasound by Mr. Last. I think that will be another hot topic on presentation. Venue will once again be provided for, moving closer to the event. Once again, this event is worth 20 CBD points, and the certificates will follow at least a month afterwards, as long. So yes, do. Otherwise, you should be here the whole day.
Everyone raise their eyebrows.
Two CPD points. As long as everyone has completed their information on the forms correctly, I'll forward the certificates in about 4 weeks' time. Then, without further ado, thank you, Dr. Lawson. We shall meet you again